A warm good afternoon to everybody, and welcome to the third session of the web series on nutritional status assessment. Um, so, before I welcome today's speaker, Dr. Geeta, I'd like to share a small story with everyone. I had a friend's wife who had come to me for counseling a few years back. So when she came to me, normally as a protocol, she came for weight loss, and I asked her to get her thyroid levels done. Her TSH was high, whereas her T3 and T4 were normal. So I told her to consult her gynec and ask her if she needs to go on thyroid medicines because her TSH was high. So her gynec told her that, TSH is high, it can be due to any other reason. So she does not have thyroid and she does not need thyroid medications. So I told her fine, because definitely TSH is high in other cases, but looking at the history that she was trying to have or conceive a baby for 2 years and not being able to plan, I really suspected that she had pre-thyroid or thyroid. 6 months down the line, she gives me a call and she says, Neha, you know what? My gynec got me to do a thyroid test and I have thyroid. So imagine, she could have started her thyroid medicines 6 months previous than what her gynec actually put her on. This highlights the importance of biochemical parameters and how important it is to get blood tests done before you actually plan and recommend diet to your clients or your patients. So today, it's my honor and privilege to invite and introduce Dr. Geeta. Uh, uh, Geeta ma'am, I have been a student of Geeta ma'am, so I know Geeta ma'am for a very long period of time. Ma'am, I'll share your CV slide, ma'am. So Geeta ma'am has a PhD in clinical nutrition. She is the director and founder of Geeta Nutri Health Consultancy based in Pune. She is also a consultant nutritionist at Gene Support, Diabetic Obesity Surgical Solutions, Oyster Hospital, Pune, Healing Touch Hospitals, Lupin Research Center. She has expertise in enteral and parental nutrition, obesity, diabetes, pediatric nutrition, therapeutic nutrition. She has expertise in corporate and school nutrition. She has worked for many years as a clinical nutritionist at Aditya Birla Hospital and Lokmanya Hospital in Pune. She has served as a nutrition expert in Protein Awareness Camp Poultry, India. She has been a corporate nutritionist with major telcos like major companies like Telco, Cummins, Mercedes-Benz, etc. She is a guest faculty at SNDT College of Home Science, Pune, Symbiosis Institute of Health Sciences, Interdisciplinary School of Health Sciences, National Insurance Academy, and All India Fellowship in Industrial Health. She is also a PhD guide. She is a life member of IDA NSIN ISPEN Pune chapter. She's also been the past president of Pune chapter and the executive member of IDA All India. She has presented and won awards at various conferences. She is a reviewer on Journal of Human Nutrition and Dietetics. She has NIH certification in clinical research, and she has many contributions in nutrition sessions in media through television and newspapers. So I'll welcome Dr. Geeta to share her expertise with us.
Thank you, Neha. Thank you so much. I just share the screen and then start.
Yes, ma'am.
Can you all see the screen? Neha, can you see the screen?
Not yet, ma'am.
It says you are screen sharing.
Yeah, it's green button. Yeah, now we can see, ma'am.
See?
Yeah.
Okay. Thank you, Neha. Welcome all. This is a beautiful afternoon actually in Pune. It's raining and we're all sitting at home. And I think the best part of this virtual conference is we all can attend from wherever we are, and we actually reach out to lot many people, because many of the times we miss out because we are physically not able to attend. So at the outset, thank you NSI Mumbai chapter for inviting me. I'm humbled actually. I'm a practicing nutritionist, and I think the expectations of my session will be while I'm practicing, while I'm applying my uh, therapies or medical nutrition therapies or counseling, what is the importance of biochemical assessments in my journey when I assess my patients? Neha has given a beautiful introduction of how thyroid was missed because the dietitian could assess that there was a need of TSH. Many of you who are practicing, who actually not even practicing, normal scenario also, even our parents say check thyroid if you're gaining weight, are you PCOS, check your sugar levels. So check your blood parameters has been somewhere a part of our now routine, and we now are considering it as a part of wellness or prevention. It's no longer a therapy. It no longer many a times come with doctor prescription unless it is a very specialized test which is being prescribed. So in such era, nowadays you also must be having a compiled pack of the blood test master health checkup from your client or patients, or you must be getting it done. And then it's important for you to understand what are the parameters which helps me to understand my nutritional status. Or it's just the disease, because any number of times we think, do I have sugar? Do I have blood pressure? Do I have dyslipidemia? Apart from getting into this, am I nourished? How is my nutritional status? Do I need to do more to work on my lifestyle? I think if that is the approach, the preventive and wellness, we have a way ahead to go when we talk about this as a technique or application in your assessment. So let's take this journey very simple, because I'm going to tell application based biochemical assessments. It will not be very, very research oriented because I'm a practicing dietitian. So I'll just take you through case studies while I'm talking. I'll take you through the importance of that particular biochemical parameters which I'm looking at. And feel free to ask any questions. I think the organizers have that uh, privilege to send me the questions which you've been asking, and we will discuss it out. So important is to know that when I'm looking at a client or a patient or a critical, we in a nutritional status, what happens is we have a critically ill patient, we have a wellness patient, we have an obesity patient, and we have a community nutrition assessments. So it's a very, very varied group, and very important is the target area. Today we are not looking at target area, so we'll be talking variety here. We'll be talking in community, we'll be talking in ICU, we'll be talking in normal walk-in wellness or obesity management. We can be talking anything because we are talking nutritional status per se, not in a particular area. So the target audience actually makes an impact of what actually am I looking for nutritional status. Like Neha said, if there's a weight gain, I look at TSH. So I know that TSH is related to weight gain. So it's important that what is the status, the current status of myself or a person, or the status of the population, like anemia, we can say um, the goiter program, which were the community programs which have been implemented, the vitamin A program, all these prophylaxis which at a community level we have looked at. So that nutritional status either in a person or in a group, and how is it related to the state of their nourishment. This is what actually is a formal definition of nutritional status. But if you look at an individual, that individual is guided or determined by complex interaction. Today we are talking about gut microbiota rather than talking about macronutrients. Human body is very, very complex. It is constituting the internal factors, your neuroendocrine immune hormones, and it is influenced by the external environmental factors. So when I'm saying internal, it's very, very individualistic with the age, sex, my food intake, my nourishment, my behavior, my physical activity, and my underlying genetics and diseases. When I'm saying external, the food safety, the cultural, the social, the economic circumstances. So it's a mixture. The environmental impact is very, very high on myself in an internal constitution. So when I'm looking at these two interactions, I actually can compile the nutritional status. So it's very simple. What I'm eating is equal to requirement or no. It's very unfortunate to know that we are eating some nutrients more, we are eating some. We don't know the RDAs, or we are not calculating the quantity of the nutrients which my body needs. We're looking at qualitative approach. We know that vegetables are good, fruits are good, but do we know that we need 400 grams of vegetables, 200 grams of food? So somewhere there's a mismanagement of quantitative approach, and that quantitative approach is something what I think is hampering our nutritional status. Because when I take a diet recall, and I think the audience here who's actually into nutrition or in dietetics, when you take anybody's diet recall, for that matter, if you start, and I want you to start looking yourself in that position today when you're doing biochemical assessment, because it is very easy when you apply what I'm saying in a day to day. So ask yourself that suppose I want to know my nutritional status. We are, of course, highlighting biochemical parameters, but let's take it to the journey of self-assessment in this nutritional status. Because each one of us may not be perfect. We might be having some challenges in our own life. In a personalized setup, community is different, personalized different, hospitalized is different. So there are n number of areas. Again, I'm not targeting the groups. I'm targeting the biochemical parameters, but we'll be looking at different case scenarios. So I was coming back to the thought process that if I have to do my own assessments, if I'm nourished, because I just said nutrient intake is equal to requirement. So if I am actually nourished or not, if I take a 24-hour recall of my own diet, what will I know? Am I eating proteins? Am I eating carbs? Am I adequately nourished with micronutrients? I would be getting an idea of qualitative balance of nutrients in my diet. Quantitative one-day diet recall is very, very difficult. Averaging that calorie protein is not going to be accurate in what I'll measure. So my diet recall is based absolutely on qualitative aspects of what am I eating. So I need to understand that if I have to actually quantitatively hit my assessments, right, then what do I do? I have a two-way of looking at it. I have a direct and indirect. Direct is very much individual measure objective criteria. For example, I want to lose weight. It's a direct measure of nutrition status. Indirect is community nutrition status, and that is why I think the iron deficiency anemia programs which are being carried out now, or the salt, reduced salt for NCDs. So these community indices is nothing but indirect way of nutrition assessments, but the direct is individual and measurable. So that is where what are the direct? We all know it's anthropometry, biochemical, clinical, and we have apart from this 24 in a qualitative, we also calculate calories and proteins. We can take an average of 1 week calorie protein if you want to work on the calculation of the nutrients. But if I want to know the quality of the food which I'm eating, balancing my food, 5 food groups, etc., it just I'm okay with 24-hour assessment of my diet. So I have anthropometry, biochemical, clinical, and dietary. This comes under the direct methods of nutrition evaluation. So today we're going to highlighting laboratory assessments, and I've already told you keep yourself in that position and start assessing yourself. Which parameters of blood does my body need to understand? And then we'll take it scenario-wise, case-wise, whatever, we take it ahead from here. So laboratory assessment is a wonderful tool now because we are all into a wellness and preventive healthcare setup, as well as we are into a community healthcare setup. I'll give it 2 minutes. Somebody's. Neha, I have got a request saying that somebody is not able to hear the audio. Am I audible?
Yes, yes, ma'am, you're completely audible.
Okay, sorry. So laboratory assessments is a wonderful tool nowadays so that we know the quantitative. I know my sugar is fasting 110. So that 110 is a very quantitative approach of myself, which I can assess through my blood values. So this lab results definitely then can be altered with a lot of other areas. I mean, I can look at my medication, hydration-sensitive diseases, whatever it is, they can be altered because if I have a dyslipidemia, my doctor generally, my medical prescription generally works with the modulating my prescription because quantitatively he's been able to look at my dyslipidemia in quantitative. Suppose he says cholesterol is 205. He said you don't need a statin. I think we'll wait for some time and then we'll look at it. So this quantitative approach is very well taken care when I do my lab reports. There are limitations and there are advantages also. Advantages I've just said, we are precise, we are accurate, right? We know that at an early stage, we can detect whatever the metabolism, the challenges in my body is taking place. Apart from the clinical appearance, if I appear pale, my hemoglobin numbers will tell me 7.5. No, she's severely anemic. Only clinical appearance may not tell me the therapeutic support of what nutrient do I need. So that's very important when I do a biochemical parameter, right? And whatever dietary method, suppose in my dietary method, I find protein intake, I'm looking at a critical care scenario. and I'm not able to look at the protein intake. I want to know the rate of malnutrition, which we'll be talking in future now. So this, I will be able to validate the data when I have a correct biochemical parameters. So it's important to know that when I am looking at an advantages, but there are limitations. Most of the research funding failed because um, it is quite expensive. For me, time consuming, expensive. These two are the things which I think it individually, yes, when we are doing it for ourselves, for when we want to manage a therapy or disease, fine. But we're looking at a larger audience, when we want to do a research, or when we are looking at a different way of looking at application based nutritional assessment status, then I think biochemical parameters um, prove to be expensive and time consuming. So, and plus we need facilities to work on it. So we all know the biochemical parameters and how it works. Only biochemical parameters, yes, you all of you agree with me. Today you're getting introduced to one of the aspects of nutritional assessment, but biochemical parameter is in conjunction with anthropometric, clinical, and dietary. If I have an anemic client or a patient, I know her hemoglobin, I won't leave her. I have to take her BMI. I have to take her anthropometry. I have to ask her what she eats. I have to look at her clinical symptoms. Maybe I'll come across a vitamin A deficiency. Maybe I'll come about many other deficiencies. So only biochemical parameters is not the way out. And that is why we are looking as one of the parameter, but it's important to identify, and actually when I'm doing my biochemical parameter test, that which biochemical parameter is important in which area. I think this is what is very important today. What we'll learn is which area and which parameter. I think this is the connection. In ICU setup, what do I do? In a community setup, what do I do? Or in a wellness setup, what do I do? So what are the biochemical parameters can I look at as a dietitian, nutritionist, so that I can prevent the further prognosis of the disease or have a wonderful health and wellness way of looking at the patient. So the two types of tests, static, function. Static, simple, the name suggests it's all. It is the measure of nutrient or its metabolite in blood, urine, or body tissue. That means what I'm actually measuring a nutrient. So iron, vitamin A. So I'm actually looking at that particular nutrient, zinc, folate, and that's a static. But it may not tell me, like I told you, that I only hemogram will not tell me that I only have to identify iron. There are other parameters with hemogram, with anemia, which I may have missed if I just look at biochemical parameters. So the limitations is I won't be able to reflect the overall nutritional status with static, but we cannot ignore this because this is also very important. Functional, it reflects the failure of the function of physiologic process of the body. So now, like in this scenario where in a pandemic like COVID, we are all looking at strengthening our immune system. So when I'm strengthening my immune system, I need to go back and learn what are the complete physiological process my body is associated with it. If somebody comes to me and say, I want to know whether my immune system is good or not, why not? And we should be able to say that how can you assess your immune status? So this complete function physiologic process of the body, if I'm able to put it as a package from that function point of view, I think then it will be easier for me to work on a functional aspect. Right? So limitations, again, it's non-specific. Only telling me an immune system may not be really looking at a nutrient-based deficiency there. So it's non-specific. But that's why we need to have a blend of static as well as functional assessment of biochemical parameters. And it all depends upon the area for which I'm addressing. We all are working in different scenarios. I'm sure the audience here is variety. Somebody wants to know wellness, somebody wants to know ICU, somebody wants to know community. At that level, we want to understand that what are the biochemical parameters which I will be useful. But today I'm saying, because you're getting introduced to this topic and it's such a vast topic, you just ask yourself, if I were to do my biochemical parameters, how do I identify the deficiencies and which test do I need? How do I work on that? So this also, if you have thought process that, okay, these are the biochemical parameters which I can highlight at this diseases or wellness, it makes my job very easy, right? So what are the nutritional status indicators? Short term, I think the appetite is very important. In 24 hours, your subjective global assessment forms, your mini nutrition assessment form, so not the MNA, that's SGA, it doesn't take any biochemical parameters. It all depends upon your appetite, right? Your nausea, vomiting, the challenges in your appetite, and the amount of food which you've been eating in past 24 hours. That's it. That's a short-term nutrition status indicator. Long term, if I want to lose weight, if I'm looking at a weight gain, weight loss, or whatever nutrition PCA management, I definitely look at body composition. It's a long term nutritional status indicator because I can't change it. So I'm looking at an intermediate term nutritional status indicator where I have my biochemical parameters. We'll talk about each one of them now. And we also look at functional parameters, that how is my mood, how is my cognitive status, any other challenges with my health, the functional parameters which we'll be looking at. So every area from a pediatric to geriatric to wellness to community, I think the challenges are different and the assessment is also different. Maybe this whole thing may not, I have tried my best to include as many biochemical parameters I can to get it introduced to you, because as I'm saying, it depends upon the case scenario which you're addressing. I may have missed out some. I just remembered when Neha was talking thyroid, I didn't think of TSH as one of the biochemical parameter because I was looking at more of hospitalized patients, so it was very difficult for me to get that TSH into this. So I may have missed out like this quite many parameters. I'll be happy to answer them, but I'm going to talk about TSH because we started with a note of TSH test in this session. So we'll take scenario by scenario and understand which test, which scenario, and why. Step one always I feel is we all are interested in PCM, because when I say nutrition assessment, more about wellness, we all look at a PCM way or the PEM way of looking at nutrition assessment. And first thing, what strikes us there is the protein metabolism, because we are actually handling a high catabolic state of disease or health or illness or whatever. So let's get introduced to how to evaluate protein status, and then we will take each one going ahead. So we all know that somatic and visceral, like fat, we have somatic and visceral. These are the two types of protein, and somatic is 75% of body's protein, and visceral, which is present in viscera, organs, in our cells, it's 25% of body's protein. Imagine this is challenging because there's not one test to identify what is a protein status evaluation. We have to evaluate with other nutritional status indicator. For me, knowing the body composition, right, knowing the MAC, the upper arm circumference, is very, very important, and the fat of the body in the anthropometric scenario is very important to work equally with biochemical parameters on protein status evaluation. But if I want to go deeper into protein synthesis and see which are the areas, where do I apply this protein synthesis and where do I need to look at protein synthesis investigation, I think we will get introduced to this now. There are four areas which actually help us to learn protein synthesis: creatinine, nitrogen balance, serum proteins, and immunocompetence. We'll handle all three with different case scenarios so that you get an idea that what are the biochemical parameters and why and where it is used, because you have to identify the case and you have to learn that, okay, I want to apply this test here, is what I think the whole aim of this session should be. And when you go back, the take back home message should be, now I'm little confident that I know what test to advise where, is what I think is my way of thinking, that you should be able to learn that. So let's start with the first one, which is the creatinine. We all know creatine, which is synthesized, is a protein, it's muscle protein, which is synthesized in your kidneys, liver, pancreas. They transport it to the blood, they take into your muscles, they take into your brains, they get broken down when you use them. It can be anything. It can be in wellness, it can be in catabolism. We're just talking about muscle breakdown. They create a phosphocreatine because they use ATP. So the ATP with creatine goes into phosphocreatine, and when you have an outcome of this creatine, this becomes creatinine. So it's a product of muscle skeleton, and we all know nitrogen needs to be recycled in your body. So it is excreted out in a constant proportion, which is equal to muscle mass of the body. So your muscle mass, wear and tear, is a constant process, disease or no disease. If it is disease, catabolism in a high amount, and this wear and tear breakdown is excreted out, and this actually is a day-to-day 24-hour process. So this creatinine help us to estimate the muscle mass. This is mostly done in ICU patients, in a critical care patients, but again, you are expected to have 24 hours urinary creatinine to get the report, because you can help to understand what is the nature of protein depletion with this creatinine height index. We know why we are doing creatinine, because it is a muscle protein. It with the muscle breakdown, it gets out through your system, and when you have excretion of creatinine, the quantity excretion, the urinary creatinine excretion through your urine, and you know that how much your body can excrete in 24 hours, you have a formula which helps you to work on malnutrition or protein depletion. And this formula is nothing but creatinine height index. For a normal male or female, it is 23 mg and 18 for 23 mg per kg for male and 18 mg per kg for female. This completely depends upon your body surface area and your height, because your protein is distributed throughout your muscles. And that is why with this formula, if you calculate your creatinine height index, you exactly know what kind of protein depletion you are, and this CHI helps us to work on it. It's a tedious thing because this is only useful in a catabolic, highly catabolic cases like in ICU nutrition, trauma, in cachexia, where you really want to know the degree of malnutrition, not on a day-to-day basis. Because checking 24 hours urinary creatinine is an expensive process and also a tedious. Because the client or the patient has to have 24 hours urine, and then that goes for evaluation, and then you get 24 hours regimen. So it's not much done nowadays, but this was the one, and which is being actually uh, published, and this is being promoted also for various reasons in critical care nutrition to understand the protein depletion in your body. The second aspect of protein depletion or protein malnutrition can be understanding the nitrogen balance. As I've already said, nitrogen consumed should be equal to nitrogen excreted. So if you want to know if I'm in positive nitrogen balance or negative nitrogen balance, and this is again in a very highly catabolic clients, post-operative, burns, cachexia, cancer patients, or prolonged illness, malnutrition, starvation, right, or trauma, or any ICU or critically ill patient. Even if you have a patient on ventilator, need not be having any specific, but he can have multiple, like MOD, that is multiple organ failure, and on a ventilator, and you've not fed him for a long period of time, and you want to know the nature of malnutrition in him, I think this nitrogen balance is a very easy way to look at it. And you know by name, positive nitrogen balance is intake is better than loss, and negative nitrogen balance is loss is more than intake. And we all know that in ICU patient or in a critically ill patient who have to be fed through tube, or who are nil by mouth, or who are really struggling for the vitals to get normal, it's a great challenge for us to manage the nitrogen balance. So that is why it's only on paper we'll be adding to the negative nitrogen balance. What we will know through this is the intensity of the protein depletion through this equation. Because we all know that 1 gram of nitrogen is 6.25 grams of protein. So when I have a balance equation, I know my protein intake. Suppose I give 60 grams of protein, I divide by 6.25 minus urinary nitrogen minus 4. 4 is my losses through sweat and urine and other areas. So this is more easier way, but again, I need a urinary nitrogen to help me understand 24 urinary nitrogen to help me understand, am I in positive or negative nitrogen balance. This is done in most of the ICU patients or clients to know what kind of malnutrition they are. But in today's scenario, we all take it for granted that my ICU patient is already malnourished. He is already in a negative nitrogen balance. Depending upon the illness, the nature of negative nitrogen balance increases. How much I'm able to feed him, a catabolic state of his body tells me that what kind of a protein depletion equation I'm looking at. So these are the two very calculative way of looking at the number, or numerical way of looking at the degree of malnutrition, especially in a critically ill patient or in a hospitalized, but mostly in a critically ill patient. The third protein synthesis part is serum proteins. Now this serum proteins, if you look at it, it's a group of tests, which will be coming to it now. But it is useful in assessing protein status. Generally, what happens is this serum proteins, we all know that patient's response to nutrition support. I'm feeding him 100 grams of protein through the Riles tubes. I'm giving him parenteral nutrition. But still, I see large amount of muscle wasting in him. I'm sure you must be having. requirement is very high, especially if I have a burns patient or if I have a trauma patient who's being inhaled by mouth for a long period of time. He's lost so much of muscles, the catabolism still continues. He's already on a ventilator support. He's being in ICU for 10, 12 days. Plus, he had a history of malnutrition. In such case, the degree of catabolism is very, very high. How much ever nutrition support we give may not reach to the expectations of the requirement. In such case, serum protein assessment will help us to understand that how we can assume and what else can be done. The degree of, again, the degree of malnutrition can be assessed in these scenarios. Because the serum protein is done based on the assumption that if my liver synthesis, the protein decreases because I'm utilizing it more, definitely I'll have an impact on my serum proteins, which will anyway decrease. But limitations, it always cannot determine extent to which nutritional status or liver function affects serum protein concentration. But it is done most of the time. The albumin, the globulin, we'll talk about it. But before you do any test, before you go, like I told you about creatinine, why am I doing creatinine? Why is it an indicator? How will I know that from creatinine I'm trying to work on protein synthesis? So the nature, go back to creatinine and learn about what the function of creatinine and the physiology of the creatinine. It's easy for you to assess because one creatinine can tell you a lot of things. The muscle breakdown, the dehydration, the renal parameters, right? I have taken creatinine from protein depletion point of view. So similarly, if I'm talking about serum protein and if I have albumin here, and I should know about albumin. Why am I looking at albumin? Right? So first we'll talk about introduce albumin and then we'll take it further that which assessments will albumin helpful for. So we know that albumin is synthesized in the liver, right? That is the weight of albumin, the kilodalton. It is soluble in water. Half-life is 15 to 19 days, right? The main function of albumin is binds, it transports, it's a transporter of many free fatty acids, amino acids, phospholipids, hormones, and many things. So my albumin is used as a carrier in my body. It is transports a lot of nutrients from my liver to other parts of the body. So it's a part of my extravascular fluid, it's a part of my CSF, it's a part of my urine, amniotic fluid, and interstitial fluid. So if I have an albumin as an assessment tool, I'll be able to understand that how is my body faring because it's a transporter. And if I have a lower albumin, that means my transport of various nutrients to the various body parts are not there. So then my risk of morbidity and mortality has been very high if I have a very poor albumin. It can also suggest, because now you know the albumin functions, it has to be synthesized in the liver. So it can also suggest apart from malnutrition, I can have a renal challenges, I can have increased infection, sepsis, trauma, it can be cachexia due to cancer, that is severe malnutrition due to starvation. Cancer cachexia is due to starvation. Trauma malnutrition is because of your high catabolism, because of SIRS and sepsis, systemic inflammatory response syndrome. So there are two different scenarios in ICU. We won't go into details, but there's a difference in the nature of malnutrition in these two areas. So liver disease, kidney disease, infections, all this will have a lower albumin. I'm only looking at albumin as a marker to help me understand nutritional status. But can I learn more about this in which area I'm looking at? Right? Because if I have a poor albumin in my report, I should really, my mind should get alert in, is the liver fine? It's a transporter, or is there a problem with kidneys? Right? Is patient starving for a long period of time? Immediately, because when I know the marker, I should be able to diagnose why is this albumin very low. Then I think we are actually learning to assess the patient and help him to come up with it. Just giving him an albumin supplement will not work. Going back to the etiology of why a poor albumin and learning, okay, his poor albumin is because he is being cachexic. So I give him PCM. I don't give him only albumin. It doesn't work. I give him calories. I give him proteins. I need to nourish him holistically, the balanced way. Then I think his body will help recover to get it back to normal albumin. Because it doesn't mean my albumin is low, I give an albumin supplement. No, it is not that way. Especially in most of the renal patients I've seen, the poor albumin means albumin supplement. No, we don't need albumin supplement. The liver synthesizes albumin. The albumin is low because of due to some reason, and that reason, if you know, then it's easier for you to help yourself to understand the parameters. But the challenges with albumin is it's a half-life is for a longer period, 18 to 20 days. And that is why it takes time for body to respond. You can't have it as a short term indicator. It only works when you're looking at a long term indicator. And if your albumin is very low, then we know that, okay, because it's a very slow change process in your body. If your albumin is low, means that's severely low. That means, yes, your degree of malnutrition is very, very severe. So you will have, must have encountered poor albumin levels in a chronically ill patients, starvation based patients, or any liver disease patients. Now they need nutrition. They don't need albumin. Albumin tells me they are malnourished. They are severely malnourished or moderately malnourished. My nutrition base will depend upon the target area of concern in my body, not only albumin. It doesn't mean if I'm anemic, I only handle hemoglobin. I need to go back and learn why anemic, which anemia. It can be simple iron deficiency anemia. It can be folate B12. So, friends, it's important that when you're assessing biochemical parameters, just learning names won't make sense. Go back to learn more of that nutrient which you're actually looking at in the biochemical parameters and relate it to it. The second serum protein we should be talking about is globulin. And in today's, I think, pandemic, we're all talking about immunonutrients, immunoglobulins. We've been into it. And that is why we should know that what is this A by G ratio? What is globulin? How globulin will help me? And which areas the globulin is important? I think all this will make a lot of sense. Globulin is also a group of protein. Before we get into the details, we would like to understand this, what is globulin and the difference between albumin and globulin. Albumin is very simple, what we've discussed. 60% of total protein is in the albumin form. But when I'm looking at globulin, I have four fractions of globulin: alpha globulin, beta globulin, uh, alpha 1, alpha 2, beta, and gamma globulin. They have different, I'm not going to details, but the whole globulin is diagnosed in your blood as globulin. And we all know that the globulins, they are also proteins. Alpha globulin carries hormones, cholesterol, copper through bloodstreams. It also acts as enzyme for certain reactions. Beta globulins carry lipids, hormones, cholesterol, assist immune cells to build a response, immune response to the bacteria and virus and parasites. And gamma globulins, which we generally work on IgM, IgG, and IgA, they are all immunoglobulins. They are produced by lymphocytes and plasma cells of immune system. So now with the information of globulin, you know that, okay, globulin is something which I should know because they are again a transport proteins. They either are produced to support my lymphocytes in my immune system. They either are produced to work to step up my immune response for my bacteria, or they are carriers of lipid, hormones, and cholesterol. So it's important that I know globulins so that I can assess my immune strength along with it. And that is why when we talk about globulins, that it is also synthesized in the liver and immune system. It is very important to understand that if I say that if you want to know your immune system, there's not a single test. Like it's a protein, there's no single test. It's a group of tests. But I'm trying to work out in which area of health I'm targeting, and then I pick up. Now, in this pandemic, if people say, I want to know my immune status, right? Go with your liver panel, right? Check on your serum albumin and proteins, serum proteins for that matter. You'll realize that what kind of A by G ratio if you have. If you know your A by G ratio, it tests the measures of how much proteins you have in your blood. And with that, you'll be able to know if you have low A by G ratio, definitely autoimmune disease. If I have a high A by G ratio, my kidneys, intestine, liver may be in a challenge. So you can always relate it because you're calculating the total serum proteins with the help of albumin and globulin. So it's a very indirect way of assessment. We can't actually say that if you have a high A by D ratio, you are having autoimmune disease. No, it doesn't mean that. But it tells me in my therapeutic diet management that there is a challenge somewhere in a nutrition status assessment. Somewhere I need to have more impact of food. We need to understand that albumin, globulin is telling me about the protein status of my diet and my health. I need to look at whether is my protein going as muscle wasting. I need to push more calories in the diet. right? Or I need some micronutrients to work as a cofactor in protein synthesis, which is not there. So look at the variety of areas which I'm handling with just albumin and globulin, and this becomes very, very subjective, right? Then I come to the next protein parameter, which is prealbumin. All of us have learned and dealt this when we do ICU nutrition critical, because it is the shortest lifespan and it gives me easy indicator. But again, mind you, I am looking at degree of malnutrition when I talk albumin and protein, prealbumin. What I'm trying to communicate to you is, can I get more information from this prealbumin? Is what I think you should start talking to yourself. Because what is, like I told you, what is albumin, what is creatinine, what is globulin? You went back to that protein and understand what is the role of that protein in my body. Similarly, when I look at pre-albumin and I go back, why pre-albumin am I doing? Just to know the malnutrition? Because in academics, I've just learned pre-albumin works in a, as a short, it's an easy and very fast marker to understand the degree of malnutrition. But what is pre-albumin? Pre-albumin is also synthesized in my liver. My prealbumin is a carrier. 2 minutes. My liver makes prealbumin, right? And the main job of my prealbumin is it binds T3 and T4 and vitamin A. We know the role, like just Neha was saying, we know that if I'm having a malnutrition, my metabolism and my insulin, everything is attached, because these are all carrier proteins which I'm looking at. Prealbumin is a carrier protein, it's a transport protein. It's a very sensitive indicator for protein status because of the short lifestyle. It's a very small body pool. But apart from that, if I have a very poor albumin, what will it suggest? It may suggest I may not be synthesizing it well, so challenges with my liver health. I think I'm using too much of proteins because my prealbumin is going down. So some infections, some SIRS, some trauma, cachexia, etc. Or it may be renal challenges. But if I look at it differently, pre-albumin should immediately ask me to tell the TSH, T3, T4 values have to be checked, vitamin A has to be checked, because you know that pre-albumin binds T3, T4, and if there is not much pre-albumin, my metabolism will go for a toss. So this may not have thought. We've just looked pre-albumin and degree of malnutrition. Now let's get into the details and learn prealbumin. What is the job of prealbumin? Okay, with prealbumin, looking at T3, T4 and vitamin A is very, very important, because these are all carrier proteins. Without them, our cells will not be nourished. Our body needs these proteins to help us understand, to take all our vital nutrients from one area, from the synthesis to the target. Coming to the next protein, this is, I think, the last protein which I'll be talking about, that retinol binding protein, vitamin A. This retinol binding protein also, you will have it in your reports, and normal retinol binding protein is 2.1 to 6.4 mg per dl. So we know that this is also a carrier protein. It carries vitamin A, retinol. We know the functions of retinol. One of the important functions of retinol is I'm talking from cellular health, molecular health point of view. Eyes, yes, but it can be growth, it can be antioxidant, it can be immunity, it can be immune strength, strengthener. So there are a lot of other jobs which your retinol does. And if I know that my retinol binding protein is less, that means some challenges with my nutrition status, right? From healing to my eye care, it can be anything. So only in renal disease, I'll have this retinol binding protein increased, because my liver is not, my kidneys are not in a position to excrete it out or respond it back to the liver, and decreased generally in surgery, trauma, in other areas. So if I'm looking at visceral proteins, somatic proteins, we have a body composition, we know muscle mass, we do that in wellness, we do that in exercise physiologies. But if I'm looking at visceral protein as a marker, then all this visceral protein, if you look, the lowest half-life is on retinol. So retinol binding protein only can help me to, in a short term, because I have a burns patient or I have a trauma patient, already cachexic. Again, he's getting into ICU, not eaten for a long period of time. I want to have a quick understanding of what is a protein depletion rate. Retinol binding protein is the easiest way of looking. Can be pre-albumin, transferrin. Pre-albumin is generally done. Albumin, transferrin, and all, I think they keep telling us, because the half-life of all this is quite on a higher side. So long-term malnutrition, your serum resistant protein can give you. So I think you're getting on me that, okay, which area, which biochemical parameters we can relate it to. The next I would like to highlight is insulin growth factor. That's also another parameter which we check in PCA. Why do we do that? Because we know that again IGF is produced in liver. It is stimulated by pituitary growth hormone. Again, the short life, the half life is very short, just 24 hours. And it is bound to plasma with a protein, like you have IGF binding protein 3. That is insulin growth factor binding protein 3. So it moves in your blood through a binding protein. So what inference will I get if I know IGF? I mean, only IGF. I know that it will help me to understand PCOS. It will help me to understand insulin resistance and other areas. Apart from that, what will I know? I know that my insulin is response to is in response to starvation. So if I have a fasting of more time, my IGF-1 levels gets lowered more than 4 times. My deprivation, my starvation of my body is easily, if I have a very poor IGF, I know my patient is starving, I need to feed him immediately. EN, PN, oral, whatever it is, because it suggests that my body is in a depletion. And that is why it's a very easy and a good marker to understand. Even if I have IGF, I'll be able to know that what kind of starvation. Higher IGF, definitely I know that it's depletion. Interestingly, IG is not influenced by inflammation, and that is why it helps us to understand nourishment from calorie protein point of view, not a specific, but depletion of my health can be worked out very easily with IGF. The next part of the biochemical journey, parameter journey is, I think we'll go to the transferrin now. Because when I'm talking about all this, it's more about to understand that these are all carrier proteins. They carry some protein, some parameter with them, some marker with them. The marker has a job. Most of them are synthesized in liver. What is the job of that marker? Once I know that marker is related to these areas, then I think with that I need to work. If my IGF is low, I know I'm starving, right? Then let me check that if I'm starving, I'm hydrated, sodium, potassium, electrolyte imbalance, right? All that my mind should start working immediately, that because I relate one after another, because I know what my IGF does. So similarly, when I come to this transferrin, because we actually do only one thing, acha, sugar jada hai, diabetes, khatam. Why not look more deeper into it and learn that what are the other parameters which can be associated with this parameter, and I can help the client into that direction. So similarly, when I talk about hemoglobin management, you can't ignore transferrin, but transferrin is one of the protein also to help me understand my protein synthesis or degree of malnutrition. Because we know the job of transferrin. It is a iron, it binds iron and it transports to bone marrow. Half-life is 8 to 9 days. So we know that it is synthesized in liver, it transferrin, the name suggests it transports my iron in plasma. So when it transports, if I have a increased transferrin, right, my body's requirement is very high. I'm trying to push more iron to the areas where I need it. But if I have a decreased transferrin, that means my protein or my iron levels are getting depleted. It's either a protein level or iron level, because my body has used a lot of iron. Normal iron transferrin is 200 to 400, and increase and decrease, you can imagine how much it can. So let's go back and learn our transferrin and ferritin and another important protein associated with iron, because these are all biochemical parameters which tells me a lot of other things along with my hemoglobin status. So if you look at an iron metabolism, why am I talking about all this is because I want actually, when you look at a biochemical parameter, to go back to the nutrient which you're looking at. If I'm looking at a transferrin, I have to look how my iron is being managed by the body. So then I'll know that what am I actually looking at nutrient-based nutrition that particular patient. So if I have a normal dietary iron which is ingested, I know my stomach acid converts Fe3 plus to Fe2 plus. Most of it absorbed, most of it is not absorbed, gets excreted, excess iron gets excreted. There is a genetics carrier involved into this. There's a different mechanism from here to here, but it gets bound to your apoferritin, and you have this ferritin. This is another important biochemical parameter in iron, which is an iron storage protein. We've just discussed transferrin, which transports the iron, but we know that iron is stored in a protein called as ferritin, and this ferritin 3 to 5% is stored in your muscles, and in reticuloendothelial system 15 to 25% is stored. Rest of the iron is being transferred. It's Fe3 plus, it is bound to transfer in. 70 to 80% is transfer in bound iron, which is present. Some is in muscles, some goes into reticuloendothelial system, but most of your Fe3 plus, it is bound in Fe3 plus, not Fe2 plus. It is absorbed as Fe2 plus, converted back to Fe3 plus, and in the form of ferritin. This ferritin is bound with protein, and this protein is synthesized in liver, and that contributes to 70 to 80%. Now, this is important to understand that when I check my ferritin or transferrin, I exactly know that what is a protein level, because transferrin is a protein which is synthesized in the liver, and also what is the iron status of my body. Then transferrin, actually, if you know the plasma transferrin is only 3 mg, liver almost 1 gram, you have myoglobin 300 mg, bone marrow has 300 mg in the form of hemoglobin, RBCs, tissue micro. So you imagine plasma transferrin is 3 mg, which is being distributed into various areas. So if you are now looking at a serum protein, and only information if you want to get through serum protein is malnutrition, protein depletion, catabolism, or much, much more than that. But when you have, that all depends upon the area at which you are looking at, right? So if you just look at a simple anemia case, anemia because of some bleeding, it can be any kind of bleeding. It can be an internal hemorrhage or anything. So if your hemoglobin is very, very low, if you're 7.5, you immediately get investigated to understand. Only hemoglobin doesn't work. I need to look at my transferrin and ferritin values. I know if my transferrin is very low, my protein is also low. It's not only iron then. I need to look into my protein metabolism also. I go back and understand why do you have this poor hemoglobin? Is it poor intake or you're eating well? Because that's why poor appetite also at the same time. So I look at the complete nutrition management of this patient, because transferrin, ferritin, iron tells me more than just an iron deficiency hemoglobin. So this is about the protein depletion. This is about the protein carriers which we are looking at. Let's go to the important another way of looking at your biochemical parameters. I've just picked up the parameters which I feel is important to address, but we can just discuss it after the session if you want to know more about it. So keep writing your questions, so that while we discuss at the end, we'll go back to the parameters which I have not touched. So coming to immunocompetence. Today's time, I think this makes a lot of sense. As I told you in the beginning also, globulin, one of the important parameters to help me understand how does my body immune response is working. So it's a very indirect way of looking at it. I mean, I don't think you can say that you have a very poor immune system, you will get an infection. No, I don't think that's the way we look at it. But we will be able to assess the nutrition status of that person, and it can relate to anything, because we are talking about the immune response of the body through various cells. And we should know one is globulin, which we just discussed. What are the other cells which we are looking at, so that I understand the exact response of the bodies towards any infection, parasite, bacteria, or anything for that matter. Because any nutrition deficiencies, it leads to inflammation, it leads to infection. Simple anemia also, I'm very, very susceptible to infection. If I get exposed to any infection, I easily catch it. If this inflammation at an acute level, if I don't control, it gets converted to chronic inflammation. Can become an autoimmune also after that. So we really do not know that how we address it. So on a routine basis, if I want to know how an immune system actually, I can check through my biochemical parameters. But again, one small thought process about, not in detail, but if I'm saying immune system is such a vast physiological organ, how do I really look at it from biochemical parameters? Non-specific, we all know it's the first line of defense. So forget about it. Specific immune system we are looking, we all know that T, B, nuclear Kaba cells, these are my secondary nuclear immune system, innate immune system, which actually gears up when my body confronts with any external and agents. Like B cells, they are produced by my immune system to fight against antigen. It is a lock and key. Specific antigen, specific antibody, right? T cells, apart from any kind of antigens which my body is handling with B cell, more specific cancer cells, more specific foreign substances, my T cells work. And I have NK cells, several foreign substances. They're specialized in killing the cancer cells and virus infected cells. So these are
Excuse
my,
me, Geeta ma'am,
yeah.
can you hold your mouthpiece closer. That's the request from a participant.
Okay, sure.
Thank you, ma'am.
Welcome. So, what I'm trying to work on is if I want to know the immune system, and this immune system going back and learning that WBC, how will I learn my immune system? Right? We've talked about globulin. Now we're looking at another parameter of immune system. How will I know is if I know my lymphocytes, right? The level of lymphocytes and the number of WBCs in my lymphocytes, I can interpret my moderate, mild, and severe malnutrition status. So in such case, lymphocytes also help me, along with globulin, albumin, A by G ratio, to learn about TLC interpretation, to learn about my immune strength of my body. How will I work on my nutrition support there? Only with just talking about there's no nutrition again. Do I have a specific TLC nutrition? No, I do not have. Now I need to go back and say, why is my immunity poor? Is it anemia? Is it poor nutrition? Is it lifestyle? Go back and learn the root cause, and then, if needed, associate your immune system challenges with any other support tests. This is what is important. It's just knowing what is the immune system, it doesn't really work. So coming back to your, again, the next parameter, which is iron status. We've discussed about transferrin, we've discussed about other things, but let's understand the iron status. Because now I'll be taking you through the different biochemical parameters. We cannot do so much biochemical parameters in detail. I'll be happy to take specific questions. But whatever we are able to highlight, we will highlight, and then we will take it ahead. So iron status, if I have to look at my iron status, I have to know ferritin. So serum ferritin will tell me that, okay, what is my iron level and what is my protein level? Is there a challenge with my liver, spleen, bone marrow, right? Or I have a challenge with my simple malnutrition. I'm not eating well. Iron may not be always reduced iron in your food. Hemoglobin may be because of your malnutrition also. And that reflects on your ferritin levels. Because ferritin is your protein which is bound to hemoglobin and it is being stored in that form. And transferrin carries this. So if you have a reduced ferritin, that shows that you have reduced hemoglobin, that shows you have reduced protein. And go back to the cause and understand, why is my ferritin low? What is it, a challenge with liver or my intake or something else? Hemoglobin is a very simple marker. We all know that it just tells me my iron and my RBC, which is taken care of. Then coming to my hematocrit, percentage of RBC as compared to the entire volume of the blood. So when I know that if I have a deficiency, my depletion is present with decreased serum ferritin, decreased transferrin saturated, decreased hemoglobin, and decreased MCV. Because if I have my hematocrit, percentage of RBC as compared to the NW, so I will exactly know how much RBCs are present in my blood, and that is my hematocrit. Because when I see my CBC, that is complete blood count, I actually don't see into all this. I just see hemoglobin and I forget about it. But just take a minute and understand what are the other parameters which will help me to work is my hematocrit, which is present there. My MCH, that is mean corpuscle hemoglobin, that is how much hemoglobin is present in my RBC. So you will know the density of the RBC. When you know the density of the RBC, you will know the amount of hemoglobin present in the RBCs, right? And MCV, right? This is also important to know that what is the volume, right, of this RBC. Sorry, my slides are going up. The volume of RBCs which go up and down. If you have a low MCV, it's called microcytic anemia. It can be lead poisoning or it can be iron deficiency. If you have a high MCV, it is macrocytic anemia. So I think this is where we are actually heeding to, that if you just look at hemoglobin, it doesn't work. If you know what is mean corpuscles volume, what is a low indication of mean corpuscles volume low and high, and what kind of deficiency iron I'm looking at, that will have a better impact. So your CBC should tell you your red blood count, your RBC count, your hematocrit, your MCH, MCV. Then it's easy because hemoglobin or iron deficiency anemia is so complicated. That's why I think we, at the community level, we are struggling with it. We still don't know the answer of how to work on iron deficiency anemia, because you are not handling only iron, from protein, calorie malnutrition to folate to B12 to we don't know what else, nutrients, zinc can be added, because it talks about your malnutrition. So let's look at the metabolic panels now, each. and then we'll highlight each of them and take it ahead. Liver function test. Most of the time, we do this liver function test and learn about, and generally it is done when you feel that you have an alcoholic liver disease or you're obese. Even in pregnancy, you have fatty liver. So there are challenges with your liver, and when you do it. So when you have a raised SGPT, SGOT, which is ALT and AST respectively, this raised enzymes tells you that my liver is stressed. Reason can be many. I mean, we don't know. Then we have to go back and learn the root cause of it. The reason can be many, right? But my first mind tells me when my SGPT, SGOT is low, is my liver working hard? Especially with SGOT, am I taking a lot of drugs? Are there a lot of musculoskeletal injuries? Did I have a recent MI? So that, because see, the liver is synthesis for lot of proteins, deamination, glycogenesis, so many things are happening in liver. So if SGPT, SGOT are raised, it should clearly tell me my liver needs help. Detox it regularly, lose the weight, have fatty liver, reduce the drug exposure, and what all. Simple. It may be as simple as just working on environment, not really pushing too hard on any medical prescription, right?
Um,
If yeah,
uh, Actually, there is a pop-up that is coming on
yeah,
your.
yeah. So how do I take it out? Sorry for that. I mean, I was also feeling disturbed for that.
Probably you can stop sharing the screen and share it again.
Okay, just two minutes. Sorry, guys, for this technical issue. Okay, am I there?
Yeah.
Yeah. Okay.
Yes, ma'am.
So we were coming to liver function test, and when I said that when you see your LFTs and when you feel that one of the enzyme is low or high, your first idea should be: is my liver under stress? Am I taking over? Am I taking more drugs? Any drugs which is giving me liver challenges? And then I think we need to go back to the root cause of it and work as per the management. Just getting, because biochemical parameters for me tells a lot of other things apart from it. Tells me the areas which I need to concentrate. But if I go into the root cause of the area, I think I may have to look something else along with the liver diseases if I have. I just can't label it that, okay, you have some challenged liver diseases, go to a hepatologist. No, let me see what are your challenges. Your SGPT is raised. I think you have a fatty liver, or let me see your diet, what I can help you in diet. It will really help you that way. So coming to another RFTs, that is renal function test, you have BUN, you have creatinine, which we just tested, you have calcium, and you have CO2. So when I do my renal function tests and I have my blood urea, because you get those in the renal parameters in your blood assays when you do it. We all know that protein metabolism is very closely related to renal rate. First thing in renal function test, we do GFR, that is glomerular filtrate rate. Your doctor decides which stage of CKD your patient is in. From nutrition point of view, from assessment, because today we're discussing assessment. In assessment, what work I do should be helpful for me to apply dietetics or my therapy to that particular client. So if I see my BUN, if I see my creatinine D range, I immediately start working on reducing the load on renal. I reduce my proteins so that I try to reduce the less burden to my kidneys. Because more the protein, more the creatinine. More the creatinine, more the renal dysfunction. So this is the nutrient information which I have got from these two values. Calcium, low serum calcium can be due to many reasons. It can be basically hypoparathyroidism to vitamin D intake. So somewhere this calcium, when it is low, I cannot just relate it to giving lot of calcium in the diet. Blood biochemical parameters, when you look at that particular, it doesn't mean that, oh, calcium, come here, give him lot of calcium. No, wait. Learn. Why do I have hypocalcemia? Go back, learn about the overall physiology of the body and see that which area of the health are you relating hypocalcemia. Work on the root cause of that. If it is renal or hypoparathyroidism, you should work more on renal rather than immediately giving calcium supplements. So this is the actual crux of biochemical parameter assessment which you can take away with. Metabolic acidosis is another area because it is generally checked in ICU patients. In critical care, we generally do this to check whether the body is in acidosis, because acidosis is not good. Acid-base balance the body, and that is why high CO2 and low CO2 tells us about acidosis. Another parameters or electrolytes which gives us information is again a chlorine. We know that chlorine works with sodium to help in acid-base volume, and hence chlorine along with potassium and your CO2 values tells me about the metabolic acidosis. Low chlorine is present when your potassiums are low, when you have alkalosis, and high chlorine indicates it may be kidney or CVD. Then I come to glucose, fasting, random. That's not very important because that tells me a lot of things. But here, what do I have to tell you? You have so many GTT because that will be a topic by itself. I didn't want, because I don't look at it as assessment. I look at it as information. When I know my blood glucose value is high, when I know because we are actually looking at assessment. And when it is assessment, assessment comes with nutrition care process. You actually are what does assessment help you? It helps you in formulating your nutrition care process. And when you're giving a nutrition care process, you are actually trying to learn about hormones, you're trying to learn about the electrolytes, you're trying to learn about the internal molecular scenario in your body. So if this information, fasting and random, again I go back and say, is it weight, is it diet, right? Or is there medications will take care of it? So I think this is the information which my blood glucose will give me. HbA1c, I won't go into details. Phosphorus is related to calcium. Will have hyperphosphatemia in renal disease, and you will have hypophosphatemia in bone disease. You have sodium, you have potassium, zinc, and vitamin C. We'll go each in a short thought process. We know that where sodium plays role. Now go back. Don't look into on the right side of the table. Just start looking at the left side of the table and ask yourself, sodium. Where does sodium help me? Actually, it works on acid-base balance. It's a fluid balance for me. It works. It is actually in a channel of sodium-potassium channel for my electron transport function. So in this level, I know that if I'm looking at sodium, low sodium, I'm hyponatremic. It can be overhydration, it can be vomiting, it can be diuretics. A high sodium can be because of hypernatremia. So management of volume becomes very important when I'm handling sodium. Only cutting down of sodium doesn't really work because it is very much related to fluid balance. Right? Coming to potassium, acid-base fluid balance, nerve impulses. It is more of neurologic way I look at it, because you must be knowing that when you handle a vascular disease, especially with CVD, if you try to avoid hyperkalemia. Hyperkalemia is generally present in renal diseases, but it is very risky because it gives you tachycardia and it gives you a lot of heart vascular diseases challenges. So somewhere impulses, acid-base fluid balance, your potassium is responsible for it. Coming to zinc, enzymes, immune function, wound healing. What are the tests which is done for zinc is metallothionein, hair zinc, and urinary zinc. Your vitamin C, that is collagen formation, iron formation. You also have serum leukocytes levels to check vitamin C. I'll go back to this vitamin C, because now since we're learning a lot of a vitamin C supplements, especially when we are handling a lot of immunonutrition. Do I have a test for vitamin C? No, I don't have a test. Then how do I know how my vitamin C is there? There are a lot of research paper which actually I went through yesterday while I was doing this. That vitamin C, if you have a low serum leukocytes level and if you give a supplementation of vitamin C, it helps that leukocyte level to improve. So somewhere vitamin C is very much closely related with your immune system, and because the studies are published with this, and that is why with this leukocyte level also you can check the vitamin C, and with that you can always supplement or give it in your diet. Other metabolic panels are B6, folate, B12. We all know about it. Now, what happens is these are all cofactors. When you have your balanced diet written to your client, we talk macronutrients and we don't actually look up micronutrients, because your macronutrients take care of micronutrients. Because when you give complete balanced diet, you definitely know that I'm giving B complex and every other thing. But somewhere in an increase, when you're assessing your client and when you know the biochemical parameters are not right, and if you want to actually work on a better application, and if I have my B6, because you all know B6 is actually related to energy metabolism, to methylation, right, to your vascular health, to your homocysteine manifestation. So this pyridoxine is a very, very vital nutrient, and if I want to know that if I need B6 support or no, then I have to work on the tryptophan load test, methionine load test, PLP, plasma PL. They will tell me my B6 levels in my body. Folate, yes, we have folate test, serum folate which is generally done. And MCV also goes up, and we've just said that MCV is folate deficiency anemia, which we can actually work with when we are handling iron deficiency, when we are handling the poor hemoglobin status. B12 pernicious anemia. Another important inflammatory marker, which is generally done in these scenarios like CRP, C-reactive protein, and interleukin 6. Now, these two are important metabolic panels which are done nowadays, especially when you are doing critical care nutrition, a Nutrix score assessment. They involve IL-6 blood values, right? In normal scenario, we do CRP and IL-6 to understand the inflammatory triggers. They tell you the nature of inflammation in your body. Inflammation is reaction of your body to the environment. It can be infection, it can be any kind of autoimmune status, it can be anything. Reaction of your body to any environmental change is generally tells us that yes, I need to work on inflammation. So why? What will happen if I get this IL-6 CRP information? I will start looking at working on anti-inflammatory diet, because nutrition assessment for you and me actually is important, because with the help of biochemical parameters, it makes my job easy to prescribe. If you look at a lot of nutrition assessment protocols and forms, you will find most of the protocols not having biochemical parameters. But there are few which have highlighted few biochemical parameters, and I would like to put that in front of you. You all know mini nutrition assessment performed generally done in geriatric patients. So here they have taken lymphocyte count, albumin, pre-albumin, cholesterol. They generally take it, but they also have taken lymphocyte count along with your MNA. Prolonged inflammatory and nutritional index performer, which is generally done in critically ill patients. Because of critically ill status, they have taken CRP, C-reactive protein, and alpha-1 acid glycoprotein. Full nutrition assessment, you have serum albumin. This is also done mostly in COPD patient. Full nutrition assessment is done. I've given reference for all because these are used in various. The assessment forms are used in various hospitalized or various target group areas. They do albumin, pre-albumin, and TLC. And nutrition index, which is generally again done in ICU or critical ill, they use albumin. So if you look at biochemical parameters, when you are actually filling any kind of a nutritional assessment form, you have highlighted only albumin, pre-albumin, and TLC, CRP in some cases. But otherwise, if you start looking what we have till now read, a normal biochemical parameters, your assessment form does not actually carry so much of investigation protocols. It just tells you about your anthropometry, your dietary, 24 hours intake, right? And one of these may be helping you. So when I'm doing this biochemical parameters, before I go to the last two slides, when I'm doing any kind of biochemical parameters, my whole goal is to identify, screen, find the adjuncts to that biochemical parameter which I'm handling. I'll come to TSH now, because after this I'll be going to other biomarkers. So if I come to, if I want to understand like what Neha discussed, that where do I look at TSH, right? We've just discussed the pre-albumin, there I have to work on TSH, right? Because that's a proteasome. Thyroid stimulating hormone is my metabolism challenge. There are symptoms which I have learned what happens with my TSH. When do I check with TSH? TSH has become a routine protocol nowadays because it comes with a package one and people know about TSH as well. Lot is talked about TSH. But if I learn that I am handling obesity management, fat metabolism, insulin resistance, all these NCD areas, stress management for that matter, I think we need to look into TSH levels at that particular stage. Because it's a very simple test. Don't look at T3, T4 also. Just work on TSH. Further, doctors will definitely will help you to go take it ahead. But as Neha has explained, if you ignore this test, because it's a very simple test, and I think any dietitian can give this test. Neha, should I again stop share? There's again a window coming
Yes,
here.
ma'am. Yes,
Okay.
ma'am.
Uh, so I was talking about TSH. So if I just work on TSH,
Ma'am, it's still green. Your screen is not shared yet.
okay, it will come. Has it come?
It's still coming. I'll just let you know once it's
Okay,
there.
but till then I'll talk. No problem.
Okay, ma'am.
Uh, I'm coming to the facts of how to diagnose. Suppose you have a simple walk-in client. By now, I think we have almost ended the biochemical parameters. We'll be just talking about biomarkers. If you are now assessing for yourself, a simple way of looking at it, suppose I want to do test for myself, I will do the package which is being consolidated in a very economic way and given to me. But what do I highlight? I've learned so much today. And what do I highlight? If you all are in the age group of around 25 to 50, I should say. So in that age group, you always start asking yourself, what are the challenges of this age group? First is deficiencies. Do I have any nutrient-based deficiencies? So you actually identify vitamin, like we start with static biochemical parameters, vitamin D, iron, selenium, zinc, if you're doing all those parameters. But I just have to do a very tailor-made test for myself at this age, 25 to 50. What do? I just look at my TSH if I have any problem. TSH, I look my sugars, I look my cholesterol. But again, do I need it? Do I have any symptoms of it? I can do it if I really need to. If I have symptoms, how to identify that which test is important is more specific. Rather than doing ab lipids bhi kar lo, ab ye bhi kar lo, no need. First, if you want to check whether I have diabetes, do the TSH because I want to know your metabolism. If you're obese, you pehle TSH kar lo. Do your nutrient deficiency symptoms like check your hemoglobin, check your vitamin D, right? Check your vitamin B12. First, do nutrient deficiency, static biochemical parameters. Then, if I find some challenges there, we will take you to the journey of next biochemical parameters. You didn't see my screen, Neha?
No, ma'am, I have shared my screen
Okay.
because your screen wasn't, we weren't able to see.
Okay, we move to the next plan now. So
Yes.
I think by this time you've got, and I'm in my last three slides. So at right time, I think I'll be, my screen share has disappeared from my
So
screen.
now should I
But
go on the next?
yeah, yeah. So thank you, Nia. So now after this biochemical parameters, what I'm trying to highlight now is what next? We are all nutrition science experts, I should say. What next? Biochemical parameters today I've learned that how helpful is it in nutrition assessments, community or in specific personalized. But one step ahead, I think we should learn what are the new tools if I have to work on it. And the next, I think we should get introduced to omics technologies. We are in era of genetic evolution now, and we are in era of precision nutrition. In precision nutrition, what will happen is I look at my cellular health. I'll give you an example to make you understand also. But if I am having a susceptibility, let's say allergies, where there is no answer to allergies, I have no biochemical parameters. They do my blood test and find out the food list of where I'm allergic to, and then there's so much list of food that my client gets confused. It's better I don't get into it. This is how I look at it. So if I have a combination of my own genes, my epigenetics, my environment, which is being working on me, and now I'm getting exposed off the diet to all the body molecules which my body needs it. Now here, if I feel that, I'll give an example of continued miscarriages. When I have continued miscarriages, my doctor doesn't try to identify. I would definitely like to go in for B12. But with B12, it's important that I know folate metabolism also. Because is my dietary or drug, whatever I'm giving, the bioactive molecule of folic acid, is adequate to my patient or not? That adequacy marker we still do not have. And I think taking it ahead, if we learn at a genetic or a cellular level with the help of omics technology is a new technology which uses your DNA sequencing, your RNAs to help you understand a new markers. And these markers now are called as integrative nutrition markers. And this is the next era of nutrition trends where we now are more into biochemical parameters. Today, you got understanding a lot more of biochemical parameters are there still. But the next tool going ahead is something we have to think is this omics technology will usher me into integrative nutritional biochemical biomarkers. And I think that is the precision nutrition which we are talking about. Next slide, Neha. Neha, next slide. Yeah. So this is the precision nutrition. When I'm doing, yeah, the precision nutrition slide. When I'm doing what is the goal of assessment again? What did I do when I assessed my patient? When I know my thyroid were not well, when I know my IGF is not well, what did I do? I concluded my nutrition parameters. I gave an some statement about the nutrition goal, which I have to carry out for that. The nutrition care process was planned. Only biochemical doesn't help, but that was one of the tools which I used. So, if my ultimate goal is good quality of life and improved health status and reduced health diseases, and in such cases, I cannot ignore genetics, epigenetics, because I know that all these factors today are impact to my health. And if I'm looking at an environment, if I'm looking at my diet, if I'm looking at my genes, I need some new biomarkers and answers for the solutions which I'm not able to get it. Do I have an answer for migraine? Do I have an answer for allergies? Do I have an answer for autoimmune diseases? The biochemical markers are very simple. It is 1 plus 1 is equal to 2. I look at thyroid, I look at obesity, I look at your um, I know what with thyroid, what all I have to look. I look at your insulin, I look at your sugars. I know this is the thyroid metabolism pattern. I may look at your parathyroid thyroid levels also if your calcium is not well. So I'm linking my TSH with so many other things. But when it comes to some the other diseases where medical science has only treated symptomatically, I think now we need to work on some kind of integrative biomarkers where I think omics technology, I'm just introducing this concept to you because it's a part of the biochemical parameter test which future holds for us. Next slide, Neha. So I'm giving just an example. Only B12 doesn't work. We all know that B12, we need, if your B12 is low, as I said, no, only B12 deficiency may not work for me. I mean, I have other things to look at. I need to look at folate, I need to look at B6, I need to look at iron. So, what is the proposed biomarker in this? Homocysteine. Most of us are unaware of homocysteine because we do dyslipidemia, we check for cholesterol, HDL, LDL, and we say dyslipidemia, cholesterol, and cholesterol. We are still unanswered. He has dyslipidemia but didn't have MI. He had an MI, MI is myocardial infarction. He had an MI, but the lipids were normal. How this can? So this association is in this biochemical parameter. How do you assess it? So most of the times you need some functional biomarkers, which tells us with one nutrient, what are the other things I can use. So if you have a proposed biomarker, which is homocysteine, now this homocysteine tells me if I'm having hyperhomocystinemia, I need methyl folate, I need pyridoxine, and I need methylcobalamin because my methylation is not happening well, and that is why I'm having homocystinemia. So in B12 deficiency, suppose I'm looking at a pregnant woman with repeated miscarriages, and B12 deficiency is one of the identified risks. Just giving a simple B12 support will not work. Go back and look at homocysteine, go back and look at folate, right? And then once I enclose all that with a combination of folate, iron, B12, copper, zinc, that is why I think, friends, today we need to go back to each nutrient and understand the metabolism. I'm done here. Each nutrient and understand the metabolism of each nutrient. Then it becomes easier for us to highlight the nutritional status in that perspective area. So I think with the time limitation, what I had, I could do justice. I had lots to talk still. The topic was very vast, but I welcome the team to introduce me to the questions and interaction, if any. Sorry for any technical hitches. I hope you had an enjoyable session.
Thank you so much, ma'am, for such an enlightening session. We have a lot of interesting questions for you. So, the first question that we have is that which biochemical parameters need to be assessed under non-clinical conditions to understand the nutritional status of vulnerable age groups such as the elderly or the pediatrics? So, which parameters would we look in these vulnerable groups?
Yeah, this is what the whole goal of this session was, I think, that how do you start thinking that what parameters to whom? And this is what we've been trying to correlate. Now, when I say when vulnerable age group, let's take, for example, geriatrics. In geriatrics, what do you look at? You generally start looking in geriatric is muscle wasting, right? intake. Sarcopenia is the first thought process. Neurodegenerative and sarcopenia is the first line of thought process which you want to prevent. You don't have any non-clinical symptom here. You're just looking at wellness of this client, of this patient. So your first goal is geriatrics, first is sarcopenia. So what do? Albumin globulin ratio is a good thing. I will do hemoglobin. I may do transferrin and I may do, so you go back to your protein synthesis parameters and you start putting those parameters because you're first attacking sarcopenia. Second is go back and ask the questions about, like, you need A, you need C, you need D, all those three aspects also you need. Suppose you find challenges in dietary intake, you find the diet missing in B12, diet missing in calcium, then you can highlight. Depending upon the other assessment parameters, you can highlight biochemical. Otherwise, just non-clinical, nothing in front of you, protein or sarcopenia is the first association which you can look at.
Ma'am, we have a question that nowadays some reports show slightly higher levels of chloride or chlorine. So, what could be the reasons of higher levels of chloride in the reports?
As we discussed, chlorine and sodium go hand in hand, right? There are a lot of areas because sodium, chloride, your potassium, all these are channels through which your electron transport takes place. And if you have a higher chloride, hyperchloremia, check. First is fluid balance because it all is related to fluid. Second is go back to your sodium level and check how is your sodium level. Go back to your potassium level and check how is it, because it all talks about neurological challenges in this. And if you are actually symptomatically or non-symptomatically understand, because not always biochemical parameters are right. First, check if any symptoms of hyperchloremia, renal parameters, fluid imbalance, hyponatremia. So if you have all these parameters checked, and if it is making sense, you work on it. Otherwise, just this may be a simple fluid imbalance reason at that particular time of blood investigation, then you can take for it.
Ma'am, another question is that even though B12 is a water soluble vitamin, a lot of people who are not on B12 supplements or injections show very high levels of B12 in the blood reports. So, and even in vegetarians, they see that they have very high levels despite being vegetarians. So, is there a specific reason why, despite being vegetarians and not being on any kind of supplementation, B12 is very high? Obviously, I personally, even I have seen that B12 levels do go high on supplementation, but what is the reason for it being high when you're not on
Not on
supplementation?
supplementation. Yeah, this is of course a question marks, and I try to read a lot about it. But what my conscious and my understanding tells me that, as we've just discussed, that there are a lot of biomarkers like folate, B6. It's not only B12, because B12 your body is getting it through your gut flora, right? Your
Okay.
absorption and your metabolism of B12 is through gut flora. One MCG need not have vegetarian, non-vegetarian. If you ask me, if you have a good gut flora, your body can actually make the B12 and happily work with it. When you have a hypervitamin B12, you are fine with it. I mean, you don't have any challenges. Your doctor says ignore it. You have fine with high vitamin. You have a tendency to get into high vitamin B12. But behind the scene, if you may have some kind of a genetic or some kind of a cellular metabolism where your liver synthesis is high, where your folate synthesis may go high. So where your B12 is trying to balance your B6, folate, because all these three nutrients go hand in hand, or your liver parameters, right? Because symptomatically you have no challenges with B12. But when your blood shows a higher value of B12, I think it is something to do with your synthesis of B12, which is on a higher trend. Why do I have a higher synthesis of B12? Maybe I have a higher folate deposition. Maybe my body is trying to balance with B6, B9 metabolism, and the manifestation is into a hyper vitamin B12. We can just ignore it. It is the normal way of my body's. So that's why these nutrition biomarkers, what we just talked about, the omics technology will be able to give us answers for this. That is it harmful for me? End of the day, I just want to know whether it's harmful for me. Can I ignore it? As for now, we are all ignoring it. Just don't
Yeah.
take vitamin B12. Your body is synthesizing well. But behind the scene, I think it's the biomarkers of folate and B6 together. We need to check, and the liver synthesis, so it helps us to do it better.
So you would suggest that we suggest these people to go in for genetic biomarkers if they have
They can,
higher
yeah,
B12.
if they can, and if they are conscious about it. Till now, there is no fatality reported, or there's nothing, or no studies quote that hypervitamin B12. There is an hypervitamin of B12. It just
Okay.
shows your body has a higher tendency, and it is absolutely at a cellular level.
Okay. So, ma'am, there was another interesting question that now that we are all in the age of corona and we all been talking about the virus. have you come across any patients wherein that indicates that if the zinc or vitamin D levels are below a certain point, would it indicate that the risk of contracting the virus would be higher?
You can't be so specific in an immune nutrition, right? Immunonutrition talks about a lot of things. Definitely, vitamin D. You and me are also most of the time vitamin D deficiency. That means it doesn't mean
Yeah.
that I can I can catch infections very fast.
Hmm.
It's a combination of, because what we know, as I said, go back to the nutrient, identify its functions. The
Yeah.
function of that nutrient tells you that okay, I need to gear it up so that my immune system is better. But it doesn't mean that if I have hypovitaminosis of vitamin D, I might catch infection. I may have osteoporosis also. So I think in when immune nutrition, you cannot be specific. You just have to
Yeah.
assess, especially when it comes to, I said, you can work on TLC. Right? If
Hmm.
you have your CBC in front of you, you know hemoglobin is your first parameter to tell you about your immune strength. Your TLC is another parameter. Your height, weight. So just work on normal ABCD rather getting into details of it. And end of the day, you need to have a good immune strength with a collective response of your body rather than just highlighting one.
Okay. So, ma'am, there was another question that there are, as nutritionists, we also suggest that we need to go in for biochemical as well as other assessment periodically, like we say yearly or so. In different age groups, how what would be the frequency of suggesting to do these biochemical parameters? So, if we divide them as children, adults and elderly. So how often do we suggest like a routine health check in terms of biochemical parameters?
There are no standard protocols for it. One, you
Yeah.
are asking me personally from my experience point of view.
Yes, ma'am.
So I would say don't go for it because it gives you anxiety. So
Okay.
unless you have any symptoms, actual age of getting into this when you're premenopausal for a female and 45 plus for a male, because then you
Okay.
need some vascular health challenges, nutrient deficiencies, which needs to be regularly checked. But in an early age, if you're growing well, if you're especially in a pediatric, if you have a good growth indices, if you're playing well, if you're doing everything, unless you show any health complaints, a health complaint can be then simple energy challenge, right? Or it can be
Hmm.
micturition for a small child. Then I think there's a need to go into deep and understand where I need to check out of it. Otherwise, I think unnecessary getting into tests at a very early age of life without any symptoms or without anything should be avoided. 45 plus, yes, it is being recommended. We go with the guidelines, and after 40, 45 plus, we need to check regularly for our various health parameters for prevention and wellness.
Thank you so much, ma'am. We still have a
Thank you.
lot of
Yeah, I
all the
also have
participants
private
have.
messages on my Zoom chat for questions. So I don't think I'll be getting. I think if you can message me personally, I think I'll answer them if Neha
Yeah, because
allows
we've
you.
had all the participants have loved your session. They
Thank you.
they have all shared that you shared so much depth of information. You've actually told us that we should not rely on one single blood parameter, and we need to investigate and go back and think as to and in simple terms, we need to become Sherlock Holmes before we actually plan our diet. So that thank you so much, ma'am, for
Thank
enlightening
you,
all of
Neha.
us and. For doing this session for the members who've joined the web series, ma'am.
Thank you. I must say you have a wonderful team, Neha. I think you've been tracking me since yesterday. You saw to it that everything went well. Unfortunately, the last few minutes, the slide share went wrong. But virtually, I think you are handling it so well. Keep it going. I mean, all the best to you, and thank you to the team.
Thank you, ma'am, from the entire team to you.
Yeah, thank
Uh,
you.
thank you. I have some small announcements for our participants. The webinar feedback forms have been mailed to all the participants. Please check your emails for session 3 link. Search it in your inbox and you will get the forms. Please only open the forms after 5 p.m. because that's when we will start accepting the replies. Also, please join us again at 2:50 on Wednesday for our fifth session. So thank you so much and have a good evening. Thank you so much, ma'am.
Thank you. Thank you,
Bye,
Neha.
ma'am.
Bye bye.